Chair Durbin, Senator Cornyn, and members of the committee, thank you for conducting this hearing and recognizing gun violence as a health crisis. I am a board-certified emergency physician and dean of the Yale School of Public Health. I've spent nearly 20 years working as an emergency physician in a top-tier trauma center. Here in the U.S., treating firearm injuries is a routine part of emergency medicine. During our training, we learn how to identify who must go right to an operating room, how to crack the chest of someone who's bleeding out, and how to notify family members of a death. While in training, though, we rarely, if ever, learn to ask what could be done to prevent a gunshot wound in the first place. That changed for me about 15 years ago, after I cared for a young man, the son of a first responder, who had shot himself with his parents' firearm. He was the first patient I'd cared for who had intentionally shot himself. I couldn't save him, but he changed my perspective on gun violence. First, his death drove me to learn more about firearm suicide, to realize that in the emergency department, we rarely saw suicide attempts from a gun, not because they were rare, but because they were so often fatal. Second, his death led me to question why we didn't think about gunshot wounds the same way we think about drunk driving or heart disease, as something we can and should prevent. Most disturbingly, I noticed the difference in how my colleagues responded to this suicide compared to the everyday toll of community gun violence. Since that case, I have treated people for every type of firearm injury, from domestic violence to victims of drive-bys. I've saved some lives, but not all, and have informed countless families of the loss of their loved ones. And it is because I have had a front row seat to our nation's growing firearm injury epidemic that I have worked to define and implement a public health approach to this crisis. To clarify, this is how a public health approach works. First, we gather data on the problem. How common is it and who is affected? Second, we define risk and protective factors. What increases or decreases the chance of someone being hurt or dying? Third, we figure out programs that work to change those patterns, to avert injury, hospitalization, or death. And finally, we scale what works. We have example after example of how this four-step approach, when applied systematically, can improve human health without abrogating rights. For example, we decreased car crash deaths, as Chairman Durbin mentioned, by more than 70% over the last few decades, despite more cars being on the road, by quantifying the problem, identifying risk factors, developing multifaceted solutions ranging from reducing drunk driving to putting airbags in cars, and then by scaling what worked. Unfortunately, we have not yet consistently applied this approach to firearm injury. As a result, we are facing a growing epidemic. America's total number of gun deaths is the highest on record, and our rate nears its peak. Firearm deaths have surpassed breast cancer deaths in America. Firearms are now the leading cause of death for American children age 1 through 19. Although mass shootings get the most media attention, 2/3 of firearm deaths are preventable suicides, averaged over the last decade, like that young man I cared for 15 years ago. The remainder are mostly community violence and, to a lesser extent, domestic violence. Although there are clear risk factors and disparities, it is a problem that affects all of us. More than half of American adults say that they or a family member has been involved in a shooting. More than 3/4 say the fear of gun violence has led them to change something in their lives. The effects of this epidemic are wide and long, ranging from immediate medical costs, estimated by the Government Accountability Office at $1 billion a year, to long-term mental health, economic, and educational impacts. Mothers, fathers, friends, as well as first responders, all experience anxiety, depression, and post-traumatic stress after a nearby shooting. These dismal statistics aside, as an ER doc and public health dean, I have confidence we can turn the tide. 4 things are needed to help us apply this public health approach successfully: improved data, improved research funding, improved training of healthcare and public health professionals and community members to help us recognize and act on risk, and most of all, improved collaboration with the most affected communities, whether rural or urban. And this is where we need your help. First, help us get better data so Americans can better measure, predict, and evaluate this health crisis. You can make this happen, whether by funding data modernization for the CDC or by removing barriers to data sharing amongst state, territorial, and local partners, as Utah has done. Help us with federal funding for research to develop and evaluate solutions. At a minimum, continue current levels of appropriations for the NIH and CDC, but ideally appropriate more. Help us by supporting our scaling up and training of folks on things that do work. I'm happy to talk about this in Q&A. And finally, help our country have hope by demonstrating collaborative action, as you have done before. We are turning into a nation of traumatized survivors, but I have story after story of public health collaborations between gun owners and non-gun owners, hospital workers and community violence interrupters, faith leaders and survivors. We have shown we can reduce the risk of a shooting long before someone picks up a gun with intent to harm. Through your bipartisan commitment to this public health approach, our country can reduce firearm injury and death for all. Thank you.